obesity in America, impact on children and adolescents. My name is Amy Rothberg. I'm a physician scientist and professor of medicine in the Division of Metabolism, Endocrinology, and Diabetes, and also professor of nutritional sciences at the School of Public Health at the University of Michigan. And today, I'll serve as the moderator. This briefing has been organized by the Endocrine Society, the world's oldest, largest, and most active organization dedicated to the understanding of hormone systems and the clinical care of patients with endocrine diseases and disorders. The Endocrine Society's membership includes over 18,000 clinicians and researchers worldwide, many of whom are experts in obesity who are making significant contributions to the advancement of knowledge in obesity research, prevention, and treatment. Before I move on to introduce our panelists for today's briefing, I want to share some important information to help frame our discussion. If you could advance the slide, please. Please advance. As you can see, nearly 15 million children and adolescents in the United States are impacted by obesity. That's almost 20% of all children and adolescents in the US. 1 in 10 infants and toddlers have obesity, and 1 in 5 youth have obesity. And unfortunately, all these numbers are on the rise. According to the Centers for Disease Control and Prevention, the rate of childhood obesity has more than tripled since the 1970s. The prevalence of obesity among our children and adolescents is not only shockingly high, but it's a serious problem with serious downstream health consequences. Childhood obesity increases the risk of several conditions, such as type 2 diabetes, high blood pressure, high cholesterol, breathing problems, joint problems, and gallbladder disease, many occurring before the onset of puberty. Today, our panelists will talk more about why the alarming increases in childhood obesity have resulted in the rising prevalence of other chronic conditions like diabetes. We'll hear from the author of a study who found an increase in children with new onset type 2 diabetes during the COVID-19 pandemic. We'll also talk about how health inequities have contributed to these increased rates of childhood obesity, particularly among children of color and low-income children. Could you please advance the slide? We will hear from one of our leading experts on obesity who will share more about what it means to have obesity as a child and explain why we must address this epidemic. Both speakers will also discuss policy solutions that Congress can take to address this epidemic. But before we get started, I'm pleased to share a message from the representative for the California's 24th District, Congressman Salud Carbajal. Representative Carbajal would like to share his thoughts about the impact on children and adolescents in his district and across the country on obesity's connection to other diseases like diabetes and policy options that it can address this issue.
Hello, I'm Salud Carbajal, representative for California's 24th Congressional District. Thank you to the Endocrine Society for inviting me to say a few words today. This is an issue that has long impacted the communities that I represent on the Central Coast of California. And addressing these alarming numbers has been a priority of mine throughout my career in local office and here in Washington. During my time in Congress, I have fought for solutions to address the health disparities in our country, especially when they affect children and adolescents. As a member of the Diabetes Caucus, I recognize that navigating the change in lifestyle and diet that comes with the diabetes diagnosis is no easy feat. It can be even more difficult for children and their families. That's why I'm working on legislation to create better dietary guidelines for Americans with diabetes and other chronic illnesses. It is crucial that we continue to have conversations on how to improve the health of all Americans, and discussions like today's will help move the conversation forward on these and other important health challenges. The work that my colleagues and I are doing in Congress is only possible thanks to partnerships with groups like the Endocrine Society, and I'm grateful that you are committed to working on these important health issues alongside us to ensure the millions of Americans living with diabetes and other endocrine issues are not alone. I look forward to hearing more about the great conversations you have today, and I hope to see you in my office again soon. Hello,
I want to thank Congressman Carbajal for his remarks. His comments about the alarming link between obesity and type 2 diabetes provide the perfect segue to our presentations for today's briefing. Now, I'd like to introduce our panelists. Dr. Mónica Bianco is an attending physician in the Division of Pediatric Endocrinology at the Ann and Robert H. Lurie Children's Hospital of Chicago. She's an assistant professor in the Department of Pediatrics at Northwestern University Feinberg School of Medicine. And she has done research focused on identifying early maternal fetal markers predictive of youth onset type 2 diabetes. Today, Dr. Bianco will be talking about a study she co-authored, which found a drastic increase in the number of new type 2 diabetes cases among children during the COVID-19 pandemic, which is a direct result of the increases in childhood obesity. Following Dr. Bianco's presentation, Dr. Fatima Cody Stanford will present her findings. She's an associate professor of medicine and pediatrics who practices and teaches at Massachusetts General Hospital and Harvard Medical School. She is a nationally recognized expert in the field of obesity and is a widely cited scholar with over 170 peer-reviewed publications. She holds a myriad of leadership positions and accolades, and recently was named to the 2025 Dietary Guidelines Advisory Committee by the U.S. Department of Health and Human Services and the USDA. Dr. Stanford will be presenting on the impact that childhood obesity has on people of color and those in underserved communities. We have reserved time at the end of our briefing for a Q&A session. We encourage you to submit questions through the Q&A function throughout the presentations, and I'll select questions for Q&A after we have completed our discussions. Please do indicate your name and your congressional office or organization in addition to your question. Please note also that all attendees have been put on mute to control sound quality for our speakers, and the chat function has been disabled. I will now turn it over to our panelists, starting with Dr. Bianco. Dr. Bianco, if you would, please turn on your camera and unmute yourself.
Good afternoon. I am honored to be able to talk to you about obesity in youth and youth onset type 2 diabetes today. I would like to start by stating that this is a very important topic to me, specifically because type 2 diabetes is a medical disease that affects my family and also the community that I grew up in at higher rates than the general population. Next slide. So we will start by focusing on obesity a little, but you will hear a lot more in the next presentation. But I would like to start by reviewing the rates of obesity in the US. In the last couple of decades, the figure shows the prevalence of obesity among children and adolescents by age and age group in the United States during 1963 to 2018. Using the following information, it is estimated that childhood obesity affects approximately 19.3% of children, with 6% at extreme obesity. You can see that the age at which we see an increase in obesity is really from 6 to 19 years of age. However, that's not to say that the rates of obesity are not high at age 2 to 5. I want to point out that this is just rates of obesity and does not include overweight, which would increase this number closer to 40% of the children in the US. I would also like to highlight that the data presented in this chart is also all pre-pandemic, and we have noted that there has been a huge impact from the pandemic on obesity in this country, resulting in increased rates of obesity at much higher rates. We know that non-Hispanic African Americans and Hispanics are also more affected than Asian Americans or other children of other race by obesity. Next slide. This information is important because we know that in general, there is a suspicious cycle involved with obesity. It is well reported that obese toddlers will usually become obese children, and these obese children will then become obese teens and obese adults. Obese adults are more likely to have babies who are large and then become, again, obese toddlers. And this continues the cycle. There are many reasons why this occurs. There are genetic reasons, long-term effects of the fetal environment, the offspring, environment in which the child is growing, and nutrition and lifestyle habits. Next slide. But with the increase in obesity, we are also seeing increase in the many complications of childhood obesity. And as I said earlier, the one I will be focusing on is type 2 diabetes, and we will briefly touch on some other complications that are also associated with diabetes, including dyslipidemia, hypertension, polycystic ovarian syndrome, sleep apnea, and depression. Next slide. A couple of points I would like to highlight are that with the increase in obesity, we are seeing increased rates of type 2 diabetes in youth. Some studies have estimated that the prevalence rose by 30% between 2001 and 2009, which that's a long time ago. This disease disproportionately affects females and minoritized populations. It is more severe and with more rapid beta cell deterioration than adults, and children also have are less insulin sensitive. Using these outdated numbers, it was predicted that the incidence would increase by 13% if the incidence remained constant. However, if we use increasing incidence, it is predicted that the incidence of type 2 diabetes would increase by 178% by 2050. Using these numbers, we would expect that morbidity and mortality would increase and would result in a decrease in life expectancy of this population. Next slide. So looking a little more closely at the incidence of type 2 diabetes in youth, this graph depicts the incidence of type 2 diabetes between 2002 and 2015. The dotted line indicates the incidence in the overall population, which shows an increase in incidence over this period. It is important to note that the incidence is much higher in minority groups, with the highest incidence in American Indian, followed by African American and Hispanics. Based on this data, it was estimated that about 3,700 youth were diagnosed with type 2 diabetes per year. That number was revised in 2019 to closer to 5,000, and likely is much higher today, considering the following data that I'm showing in the next slide. So in a recent study that we conducted at Lurie Children's Hospital in Chicago, we looked at rates of new onset type 2 diabetes pre and post-COVID, and found that post-COVID rates of new diagnosis of type 2 diabetes have increased 3 to 4-fold. So looking at the graph, the solid blue line is the average of the 5 years prior to COVID, and the red line is the year following the COVID lockdown. These increases were alarming. As we are looking at data from 2022 and 2023, the numbers have decreased slightly from 2021, but remain 1 to 2 times higher than the pre-COVID numbers. This is very alarming considering the predictions discussed previously in the last slides. Next slide. In pivotal trials, looking at complications and comorbidities of youth onset type 2 diabetes, it has been noted that they happen at earlier than would be expected in the adult population, and that people with type 2 diabetes, so children who were diagnosed with type 2 diabetes, are having strokes, heart attacks, and requiring dialysis in their late 20s or early 30s. I would like to review some of the more common complications of type 2 diabetes, and these are listed on the slide, and they include microvascular complications, nephropathy, retinopathy, and neuropathy. So meaning kidney issues, vision problems, and nerve problems, hyperlipidemia or high cholesterol, hypertension, so high blood pressure, fatty liver disease, and of course, in this population, which is an at-risk population, if they are getting pregnant, they actually have increased risks for complications during pregnancy. Next slide. Some other complications that are important to follow in these patient population are things like sleep apnea, polycystic ovarian syndrome, and of course, depression and mental health issues, which affect a large population, resulting in possible eating disorders or use of laxatives in this population. So when also talking of patients with type 2 diabetes, it's important to look at social determinants of health and assessing limitations for food access, shelter, environmental stressors, and the list goes on. So they require a lot of medical and attention. Next slide. So treatment options, the treatment options are really limited in children. This is likely secondary to the limited funding of research in pediatrics and the low interest from pharmaceutical companies to make these medications available for children. Up until 2019, we only had 2 options for treatment, which included metformin and insulin. And if you compare this to the adult population, they have, more than, almost 100 different options to use for the treatment of type 2 diabetes in adults, but we have very limited options. Recently, in the last few years, there have been a few medications that have been approved for the treatment of type 2 diabetes in youth, but insurance coverage is lacking and difficult to obtain. More medications have recently been approved for obesity in childhood, but health insurance is not covering any of these medications for obesity. So it's so coverage for these medications is practically non-existent. Next slide. So why is this important? It's important to study obesity and youth onset type 2 diabetes because 1, the prevalence is increasing as well as the incidence. There is earlier onset of complications, especially in patients with type 2 diabetes compared to adults and even compared to children who have type 1 diabetes. Youth onset type 2 diabetes has higher mortality rate than patients who are diagnosed with type 1 diabetes. And again, to reiterate, there are limited treatment options that exist, and there is a limited insurance coverage for these medications that are even the ones that are approved for childhood. A combination of these factors will likely lead to a public health crisis in the future, as well as an increased healthcare burden on the system and financially as well. Next slide. Thank you. And we will have questions later, I believe.
Hello, it's a delight to be here with you today as we talk about obesity as a chronic disease that has impacted the pediatric population. It's important to note that obesity is the most prevalent chronic disease in human history and disproportionately impacts the pediatric population. As I stated, the most prevalent chronic disease in human history. I do want to talk about the language that we use when we're talking about patients that have the disease of obesity. These are patients with obesity and not obese patients. These patients have the disease and aren't defined by it. I think this is really an important consideration as we're thinking about the care for these individuals. Next slide, please. I do want to start looking at the prevalence of obesity, which was alluded to by the speaker prior to myself. I want to look at this by racial, ethnic group, and by gender group. What you'll notice here is that if we look at the prevalence of overweight and obesity, that 19.3% of pediatric individuals, that's between the ages of 2 to 19, do have the disease of obesity. We'll notice that as we cross the age spectrum from 2 to 5, 6 to 11, and 12 to 19 years of age, that the prevalence of obesity does continue to rise throughout childhood. And as someone who also cares for adult patients with obesity, these are pediatric patients that develop much significant chronic disease and obesity-related comorbidities as we go throughout life. Next slide, please. We should note that there are racial ethnic differences in the prevalence of obesity, which is multifactorial in nature. What we'll notice here is that we're looking at non-Hispanic white individuals, non-Hispanic Black individuals, non-Hispanic Asian, Hispanic, and Mexican Americans. And we'll notice differences, particularly as we look at the disparities of the prevalence of obesity. First, let's look at boys, and you'll notice that if we look at boys, that the groups known to have the highest rates of obesity are those that are Mexican American of Hispanic origin. And if we look at girls, we'll notice that those that are non-Hispanic Black girls do have higher rates of obesity compared to other groups. We'll get into some of these issues throughout the course of this presentation. Next slide, please. I do want to recognize that obesity is a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having this disease. For too many years, we've simplified this to just being a matter of eating too much and exercising too little. But what we've learned about the complex pathophysiology of this disease, that is far more complex than we've known. Next slide, please. And so I want to talk about the organ that is most important in terms of regulating weight, and that's indeed the brain. If we were to take a brain and slice it down the middle like we do in that bottom right-hand corner of the slide, we'll notice that we kind of get to the middle of the brain. And there is one period or area in the central portion of the brain called the hypothalamus. And the hypothalamus is getting signals from different parts of the brain to tell us how much to eat and how much to store. So we're getting signals from our fat tissue, our large intestine, our small intestine, our pancreas, and our stomach, and they're all sending signals to the brain to tell us how much to eat and how much to store. Next slide, please. Now, I don't want to necessarily do a large science experiment, but I do want to show you that there's two pathways of the brain by which one may regulate weight. We're going to focus on that bottom pathway first. Now, leptin is a hormone that signals from fat cells, or a fancy word for that is adipocytes. And when we go down this bottom pathway, leptin binds to a receptor and stimulates a neuron in the brain called the POMC, or the pro-opiomelanocortin neuron, in the arcuate nucleus of the hypothalamus. When we travel down that bottom pathway, we end up signaling higher levels of something called BDNF, which stands for brain-derived neurotropic factor. When we have high levels of BDNF in our body, we will have lean expression of adipose. Adipose is a fancy word for fat. That means we will appear lean. We receive an anorexigenic signal. When you hear anorexigenic, you think lean. And those people that have high BDNF levels will typically signal down that pathway. Now, I'm an obesity medicine physician. I exclusively care for patients with overweight and obesity, so my patients don't signal so well down that pathway we just talked about. Indeed, they signal down an alternate pathway where leptin binds to a different receptor and stimulates a different neuron in the brain called the AGRP, or the Goody-related peptide neuron, in the paraventricular nucleus of the hypothalamus. These patients get an orexigenic signal. Orexigenic, opposite of anorexigenic. Not only will we see increased food intake, but also increased food storage. This is really important. I want you to notice that I have not said anything about willpower. This is how the brain signals, and how the brain signals influences our weight status. And this is a really important piece of the puzzle. Next slide, please. So we're going to look at a few different factors. I'm going to take you away from that complex pathophysiology to go with the next thing. So press our button. Next, we'll get to the brain. The brain is the central organ that's regulating weight. And the next factor that we want to pay attention to is food quality. Food quality is extremely important. We want our food to look like what you see on this slide. Lean proteins, whole grains, fruits, and vegetables. But just because it looks like this does not mean we won't have the disease that is obesity. That is some of the stigmatizing information that we project, and this is false. Let's go to our next thing, please. And I want to talk about one of my favorite pastimes, which is physical activity. And we sell the wrong messaging as it relates to physical activity. We say people go exercise, lose weight. And when they don't lose weight, what happens? They stop exercising. The problem that we need to be aware of is that for exercise, on average, it helps us support weight maintenance. So if you think about your favorite NBA player, whatever your sport of choice is, do we see them losing weight between games, or do we see them maintaining their weight? And so that messaging needs to be changed also. Next factor, please. Sleep quality and duration plays a large role in how the body regulates weight. Believe it or not, this starts in early childhood, and studies have looked at individuals between the age of 3 and to their 30s and show that if we have short duration sleep, it affects body weight status later in life. Next slide, or next area, please. Medications that we prescribe for individuals can have huge implications for weight gain. Medications like lithium, Depakote, Tegretol, Celexa, Cymbalta, Effexor, Paxil, Ambien, Trazodone, Lunesta, Gabapentin, Glyburide, Glipizide, Glimepiride, Metoprolol, Atenolol, Propranolol are just a few of the medications that can lead to dysregulation in those pathways that lead to greater storage of adipose tissue, which means greater expression of fat. Next. Now this is, it looks like another sleeping person, and you're like, Dr. Stanford, did you mess up on the slide? And I'm going to say, no, I did not, because this person is sleeping during the daytime. Now, when we have circadian rhythm disruptions, which means that we deviate from the natural rhythm of the body, we should be awake when it's bright outside and sleep when it's dark outside. But when we deviate from this, this can dysregulate those pathways that regulate our food intake. And then finally, thermogenesis, which is how much the body burns at rest and with activity. A lot of this is genetically determined, but all of these play a role in how the body regulates weight. So next, please. And let's go to our next slide. Now, I do want to talk about this BDNF. I just taught you guys something really complicated, and that's about brain-derived neurotropic factor. When we have those high levels of brain-derived neurotropic factor, we have lean expression of adiposity. Now, when we look at this racial ethnic disparity in obesity, a lot of times we point to just the socio-determinants of health, which are definitely important, but I want to go a little bit further and look at some of the genetic basis for some of the differences we see in weight status across racial and ethnic minority groups here in the US and around the world. What I want to note is that if we were to look at people that have on the left side of the screen a TT allele pairing, they have high levels of BDNF. I want you to see that green arrow showing that if you have high levels of BDNF, no matter what you eat, you tend to be a bit smaller. Now, we can see the CC allele pairing on the right side of the screen, where if you have that pairing, you tend to have low levels of BDNF and you tend to express adiposity, which means express weight. Now, in this particular study that looked at over 30,000 individuals, they found that those that were non-Hispanic Black, like myself, or those that were of Hispanic origin, tended to have a higher likelihood of having that CC allele pairing, accounting for lower BDNF and greater expression of adiposity. Next slide, please. And I do want to point out things that we start to see very early in life, where you're listening to the Endocrine Society, and we want to think about things that happen really early, particularly as we look at, for example, the higher prevalence of obesity in those that are non-Hispanic Black, like myself. What we can see in this left diagram is that the acute insulin response to glucose, that means how our bodies respond to glucose, are very different if we're of African origin versus not. You'll notice that that top graph shows that all these stars, right? This is highly significant, and that those that are of African descent tend to have a much higher response to glucose. Now, this also is something that we need to look at when we look at estradiol, and that's just a fancy word for estrogen. As we move through our pubertal stages, we'll notice estradiol does increase, but you'll notice that this is significantly higher amongst those that are of African descent. Next slide, please. Now, I particularly really like this slide. And for those of us that are pediatricians, we think about something called Tanner staging, that development from being a child into an adolescent into a young adult. And what we'll notice, particularly in this figure 3, is that if we're looking at those of African descent, that we tend to progress down adolescence a bit quicker. And that's something that's significant starting really early at the age of 8. But why is this important in terms of looking at fat mass? And now I bring you to figure 4. Where we see that the percent fat mass increase per year differs in those before they get a menstrual cycle. So in the white block, those are those that are of Caucasian descent versus those that are of African descent. And you'll notice that percent increase in fat mass is actually higher in those that are of non-Hispanic white origin before they get their menstrual cycle. But I want you to notice the right side of the screen, once we look at after menses has happened, after someone has gotten a menstrual cycle, that there's a greater accumulation in fat mass which appears to be triggered by going into having menses. And that's something that a lot of people are unaware of. Next slide, please. I do want to talk about this long-term impact of childhood sleep on obesity. This is one of the best studies done to date, looking at the body mass index for short, moderate, and long-term sleepers. Now, it's going to be hard to look at the moderate and long because those boxes look the same, but I want you to look at this looking from age 3 to age 32. And if we follow this trajectory, we notice that those BMIs are higher in those that have had short sleep over the lifespan. So what we're doing at 3 years of age impacting what we're seeing in those that are in early adulthood in their 30s. And next slide, please. I do want to talk about this. Dr. Bianco mentioned this, and I want to show you how body mass index did change during the COVID-19 pandemic. We're going to be looking at a few different age groups. We're looking at those between 3 to 5 years in age, and 6 to 11 at the top, and in the bottom, 12 to 17, and then 18 to 20. Now, I want to pay attention to what these different lines, meaning that kind of dark line that you see is severe obesity. So you'll see that we had a greater rise in severe obesity in those between 3 to 5 years of age and 6 to 11 than in those older age groups. So this shift in the whole milieu of the world with COVID had a major impact. Once we get down to those other levels, we'll notice that everything at the bottom is lesser degrees of obesity. But like I said, paying attention to that dark blue line and seeing that major shift. We saw a shift in 12 to 17, was not quite as pronounced in 18 to 20-year-olds, but I do think we have to recognize this was a major inflection point. And we also have to recognize that COVID-19 became the greatest risk factor for both sickness, hospitalization, intubation, and death, not only here in the US, but around the world. Next slide, please. I also want to talk about this influence of early issues with weight and weight status contributing to higher rates of adult obesity. So in this particular study, this is what we call a GWAS, fancy word for genome-wide association study, where we're looking at BMI scores starting really early in life, starting at age 0, basically as an infant, and watching how that effect has an impact into adulthood. And what you can see here is that having that early onset obesity does project into adolescence and into adulthood. And so we need to make sure that we're addressing this issue early, aggressively, and making sure we're not ending up with adults with greater burden of disease, greater impact on our health system, and then of course, reduce quality of life in those individuals. Next slide, please. In this particular issue, we're looking at body mass index across the life course. We're looking at the emergence of race by sex disparities in early childhood. And in this particular slide, we don't have to go into the specifics, but what I do want to point out is that we start to see with Black children, Black girls particularly, that this deviation between who is more likely to have obesity tends to be very persistent in my demographic, and that tends to go all the way until the age of 50. So this disparity in weight status continues to persist and of course affects health outcomes later in life. Next slide, please. I do want to talk about ethnic disparities in childhood BMI trajectories in obesity. And this is actually taken from international data. You'll notice that this is looking at the World Health, WHO, or the World Health Organization, along with the CDC. And I want us to look first at the left side of the screen where we're looking at boys. And I want you to notice that if we're looking at that green line at the top, we're looking at Hispanic boys as having the highest rates of obesity, and that large trajectory that we see as we are going up the age spectrum. Look at the age in months at the bottom axis for us to look at that. And similarly, as I've talked about throughout the course of this presentation, those that are girls of African descent, like I grew up, you'll see that higher rates of obesity within that cohort. Notice that purple line in that right diagram noted there. And next slide, please. I do want to thank you for your time, and I want to turn it over to Dr. Rothberg for questions.
Thank you both for those outstanding presentations. I think we'll now turn to our Q&A. I want to first turn and ask you, Dr. Bianco, your study focused on the increases in type 2 diabetes among children during the pandemic. We know that increased rates of childhood obesity are a contributor to that, but can you talk or share a little bit more about those connections between childhood obesity and type 2 diabetes?
Of course, we know that, as your weight increases, we start to have increased resistance to insulin. And that happens to everybody. However, those who have that genetic predisposition to having type 2 diabetes, this increase in insulin resistance or inability to respond to the insulin that your body produces will increase significantly, resulting in earlier onset of youth of type 2 diabetes. And that is the alarming thing, is these increases in obesity really will result in these large increases in patients who have type 2 diabetes. And that, again, as I discussed, will result in a lot of the complications from diabetes, which can be very severe and affect both the health of the patient, as well as the ability for them to live life, a full life, especially if they've had things like heart attacks and strokes at a young age of late 20s or something like that.
Thank you. Dr. Stanford, as you know, obesity was declared a disease well over a decade ago in 2013 by the American Medical Association. Now we're seeing these just staggering rates of childhood obesity, something that we did not witness or was unheard of about 15 years ago. Can you share your thoughts on why the obesity epidemic has not been taken seriously?
Absolutely. Thank you so much, Dr. Rothberg, for that really important question. I think that we have seen obesity as a moral failing, a personal choice that a person has, that, if they just do something better, that we can be better. And this personal responsibility dynamic has led us to not really taking this seriously. Unfortunately, obesity is a disease that you wear. It's not something that you can hide. And with that comes the stigma associated with the care that we provide, and the stigma associated with, I would say, the entire public response, whether that's from Congress or other stakeholders in addressing obesity as a chronic disease. We'll notice that there's a diabetes caucus in Congress. There is not an obesity caucus, despite the fact that it has the highest prevalence in terms of both the pediatric and adult population. I think we need to start treating this patient population with the dignity and respect and with the care that they deserve, like we do other chronic diseases. And I think that we can start now and hopefully change the trajectory of what we've seen over the last 15 years.
On the heels of what you just said, there is a lack of access to obesity treatment and care. Lifestyle interventions like intensive behavioral therapy, known as IBT, and pharmacotherapy for weight management are scientifically proven to facilitate weight loss and result in overall health improvements. Can you talk a little bit more about that and share some possible policy options to address those problems?
Absolutely. Dr. Bianco mentioned, for example, that we have a variety of therapies that are available in the adult population that are also approved for the use of pediatrics. For example, when we're looking at pharmacotherapy for the treatment of obesity, sometimes this is inaccessible because many companies, our insurance companies, have yet to begin to cover these treatment options. We see similar issues with those that are covered by Medicaid, right? Those with the lowest socioeconomic position, and recognizing that those individuals unfortunately have a higher predisposition to obesity due to the social determinants of health. A metabolic and bariatric surgery, which is approved and considered to be a viable option for those with severe obesity in the pediatric population. While we do have better coverage of those, we need multidisciplinary centers that are able to care for these patient population in a longitudinal fashion. So in order for us to really make shifts, we have to be thinking about the whole person, thinking about the need for longitudinal care. These are pediatric patients that need comprehensive multidisciplinary care. And I think that we can begin to move in this way if we begin to think of this disease like we do others, much like the type 2 diabetes that Dr. Bianco mentioned in her presentation. And if we can begin to think of this in the same fashion, in the same way, I think we can make some progress and really shift the narrative for this patient population.
Dr. Bianco, as we've all said and known for a long time, prevention is critical if we're going to solve this crisis. Can you talk about why prevention is so important and what can be done to improve prevention of both obesity and diabetes?
Of course, and definitely, prevention is important, and it is something that we look to significantly in the medical field, and it is something that is very important for all of our general doctors, both in youth and in adulthood. There are many different laws and programs that are funded through Congress, where we are able to extend prevention and preventative treatments and public health programs that are also critically important. Specifically, the Chronic Care Center at the Center for Disease Control and Prevention is integral in improving public health. And this includes important work being done by the CDC's Division of Nutrition, Physical Activity, and Obesity, and effective programs such as the High Obesity Program. These are all programs pertaining to child nutrition and food security, such as child nutrition programs and the Supplement Nutrition Assistance Program, or SNAP. The Endocrine Society has additional information about these programs, and they will be sharing some of this resources after the briefing. But, of course, as we have said, there are definitely environmental factors, and, being able to address those is important. But it's also important to allow people to understand that there are also genetic and factors that are less modifiable, and that accepting of medical treatment is also important in this process.
Maybe a question for either one of you. You know that obesity also has a major impact on costs. Recent studies have found that the medical care costs of obesity are almost $150 billion per year in the US. This actually represents over 6% of GDP. How could addressing childhood obesity have an impact on our healthcare costs?
So I'd love to jump in here and talk about this. I think that if we can begin to address this disease early, we can decrease healthcare costs into adulthood. We want happy, healthy, functioning members of society. And unfortunately, when you have obesity and the over 230 plus diseases associated with obesity, that's not a feasible option for those that struggle very early in life. That leads to, poor outcomes later in life. And then the financial burden is significantly high. Dr. Rothberg, the numbers that you gave are actually some of the more conservative estimates about the cost of obesity. So we think that is significantly higher than this. Why not treat this disease early and decrease our health costs? More than 20% of our GDP in healthcare is being spent on obesity. Why is that? It's because we're not treating the disease. We're treating all of the downstream impacts. And if we just treated the core issue, which is the obesity itself, you would have the pleasure of doing what I do with my patients, which is actually deleting diagnoses from patients' chart. As I treat their disease, I may actually not know how to bill the patient. That's a great problem to have. And that means that I'm doing my job effectively and I'm caring for that patient in a way that's reducing the burden of healthcare costs in our society.
Dr. Bianco, do you have anything to add?
I could not agree more. And it is very, very important. And I mean, one of those complications or diseases that is associated with obesity is type 2 diabetes. And I think when you have those two together, that it leads to even more healthcare costs, healthcare burden, and burden on the patient themselves. So really, obviously treating the problem before it gets to that would be essential.
Thanks so much. So I want to open up for questions from the audience. Please send your questions through the chat, through the Q&A function. As a reminder, please, when you submit your question, attach your congressional office or organization. I'll just pause for a second there and look at my Q&A. Okay, well, I'm going to turn then and ask another question. And we know that our children do not live in vacuums, right? So fundamentally, and perhaps Dr. Stanford, you can address this. What can we do to address children who are living in an environment whose parents largely dictate what they are going to consume, at least in the early years, and how they are going to live?
You know, this is a really big question, and one that I won't have a great answer for, because I think this requires so many different sectors to be involved to really address the underlying issues. You know, lack of generational wealth, racism, trauma, all of these are part of that, the built environment. And one of the things that I'm unable to change as a physician for my patients is their lived experience, where they eat, live, breathe, pray. These are things that I don't have really any jurisdiction over in my healthcare domain. But I'm clear that these things affect the health that the individual is going to have, the likelihood of them having obesity. And so I think we need to be thinking about the whole person. We need to be thinking about financial constraint, and how financial constraint in and of itself is going to lead to a higher likelihood of having obesity as a disease. Providing resources that allow for a good nutritional environment, but still recognizing that some of our federal programs do fall short of ensuring that our patients have the best diet to ensure the best possible health. But all of these factors are going to be germane to looking at that individual that unfortunately starts off with life circumstances that don't allow them to have the same access that someone that's growing up with me would have in a highly insured environment. And I think that this is extremely important for us to recognize that our healthcare is not working in a silo, that we need the government, we need the communities to all play a role in ensuring the optimal health of the individuals that eat, live, pray, and dwell there.
Thank you. So we have some questions from the audience. Dr. Bianco, can you explain the difference between obesity and overweight?
Of course. So obesity, and in childhood, it's a little different than what we would do in adults. We do look at percentiles. And so we have these curves. I'd love to have a picture to show you guys, but they are based on the weight and the height of the child for their sex and age. And then there are curves, and a child is a normal weight if their BMI percentile is between the 5th percentile to the 85th percentile. Is normal weight. Overweight is 85th percentile to the 95th percentile, and above the 95th percentile would be what is considered obesity.
Thank you. While genetics are clearly very important to outcomes, we do know that healthy food access is vital. Do you believe that current government health programs and health guidelines provide accurate health information? Dr. Stanford, I'll leave that to you.
As a member of the guidelines committee, I will have to not speak on this specifically, and I can't say anything until October 2024. So I'm going to defer to Dr. Bianco just to keep my non-paid job on the committee.
Very good, Dr. Bianco.
You know, when we're talking about government programs, I know that there have been some changes in terms of the types of foods that are offered in those programs. And so sometimes that has been an issue in the past. It is important to reevaluate what is offered in programs such as SNAP or WIC, and look at things like that. We have a lot of evidence showing that juice is not something that is necessary in the diet. And as pediatricians, we try really hard to make sure that families stay away from juice being a primary type of nutrition for their young kids. And so really, making sure that we are working together, both in the medical community with programs like this, to improve what is offered to the community, I think is essential.
Again, tagging on to that, how helpful do you think are produce prescription programs to fighting childhood or adult obesity?
So I can speak on this. I do think that the prescriptions are helpful, but I do want to talk about this interlinking of food insecurity and housing insecurity. My parents actually have run a food pantry in Atlanta for the last 30 years. And now in their setting, they are able to get fresh produce, fruits and vegetables on a weekly basis to distribute to those that attend the food pantry. The problem is if you have housing insecurity, what are you going to do with this fresh produce? If you are living in a shelter, do you go and just prepare, those fresh fruits and vegetables on the stovetop that you don't own or don't have access to? It's not really reliable, and it's not something that they can do. What they often find after they complete a food pantry day, which is actually today's Thursday, when they complete this, they actually find a lot of the fresh fruits and vegetables that were distributed to those individuals scattered along the parking lot in the church that they run the food pantry. And so you might wonder why. Something as simple as not understanding that corn does come on a cob. They've asked my parents, well, why is the corn on this thing here? Not being aware, because they've never seen corn in its native form, that it actually comes from a cob, and that's where we get the corn from. Or not understanding some of the fruits and vegetables that are there, how you prepare them in a way that's healthy for the environment. So I think we have to go beyond just those prescriptions and understand that the entire environment, the education surrounding these fruits and vegetables is going to be extremely important in really shifting the narrative surrounding consumption.
So is the calories in, calories out model flawed?
Yes, this is one thing I have a firm answer for. We have been talking about it just being about calories in, calories out, like we are some inanimate object that doesn't respond to the environment around us. This is not at all the case. If we were to, for example, just follow rules and deduct 500 or 1,000 calories from our diet, it states that we're going to lose between 1 pound and 2 pounds a week. But to when? Do we go to zero? No, nobody goes to zero. So it shows you that there are other factors that are playing a role. If we go to zero, we cease to exist as human beings. And so we have to think about this complex pathophysiology. It's not just about calories in and calories out. We all know those individuals that can eat much higher calorie burden and appear never to gain weight. And then we see those people that may have a lot of excess weight that actually are eating significantly less. So we have to delve and go beneath this idea that's been flawed for so long, that it's just about calories in and calories out. It's wrong. We need to dispel that myth, and then we need to treat the individuals that are struggling because their bodies don't quite signal down the right pathways.
So one last question. Grand ideas. If healthcare were to accurately and equitably address obesity, what would you all want it to look like? What laws do you wish had been done, and what laws would you like to be seen enacted in the future? When I say laws, policies.
Yeah, I'll start. I'll let Dr. Bianco, pick up. Right now, there is no comprehensive policy to address obesity in either the pediatric or adult population here in the United States. I find this to be disheartening, particularly because if we're looking at the pediatric population, we address that 19.3% of the pediatric population have this disease of obesity. And based on 2018 numbers, which are the most recent numbers we have for adults, we're talking about 42.4% of US adults. We're still waiting for the recent, or the most recent NHANES data, the National Health and Nutrition Examination Survey data come out. But yet we have no policy to address this disease anywhere in the United States on a comprehensive basis. We're going to continue to fail the citizens of this country, our patients that we care for, when we don't recognize that this disease is rapidly growing. There's multiple factors that need to be addressed. We need all sectors to be involved: healthcare, government, faith-based institutions, schools, and other entities to be involved in really addressing this disease. Until we begin to address the complexity and all of the multiple factors that play a role, we will not make a dent in obesity as a disease. And we can do it, though. We can do it. This is not as simple as, something a lot of times we hear tobacco policy used to kind of look at what we could espouse to do. But this is not as simple as just stopping smoking. I mean, everyone has to eat to live. This is going to be a part of something that you just have to do if you want to remain human and here on Earth. And we have to recognize that it's just beyond the food environment, and all of these factors that we've talked about previously play a role. I think we can do that. We have to recognize that because it's a challenging problem, there will be no easy solutions. We can do the work if we're willing to put the work in.
Thank you. Dr. Bianco, anything?
No, definitely. Again, yes, this is a multifaceted problem. And I think that to address it, you can't just say, one group will address it. Of course, in the medical fields, we will continue to do our part as part of preventative care and information to families. Of course, there is room for government support and help for public health programs, as well as policy that I believe can really kind of help make a change, and as well as campaigns to improve activity and really inform the population at whole, what is nutritional, promotion of nutritional substances and things like that, and really decreasing some of that promotion that we see a lot in kids. A lot of kids are watching YouTube and all they see is fast food advertisement for soft drinks and things like that. And so really looking at things like that and making sure that we can make some changes in those aspects as well. So again, not an easy problem to fix, but I think that there's definitely ways for us to make shift that curve and make it so that we are starting to decrease in obesity.
Right, the health system alone cannot manage it. We'll have to move beyond the medical model, I think. So I want to thank again our panelists. On behalf of the Endocrine Society, thank you very much for attending this briefing, Obesity in America, Impact on Children and Adolescents. We hope you found this discussion helpful and realize the urgency of addressing this issue. Before we conclude, I want to summarize some takeaways from our briefing today. The Endocrine Society encourages you to review the obesity resources on our website, including our obesity playbook shown there. The playbook is a go-to resource guide for congressional staff, which includes a 101 background information on obesity, scientific information, policy options, information on what the administration and federal agencies are doing on this issue, and a list of Endocrine Society members who have expertise on obesity. We encourage you to review this information in the playbook regarding the current barriers to obesity treatment and care and the policy options to address current coverage restrictions. We also encourage you to consider the importance of obesity research and prevention programs, including the Childhood Obesity Research Demonstration, or CORD project, which is up for reauthorization this year, and the High Obesity Program, which is housed at the CDC's Division of Nutrition, Physical Activity, and Obesity. You can also review the information in the playbook pertaining to child nutrition programs and food security. After the briefing, we'll follow up with you to share the resources that we discussed, including the playbook and an educational fact sheet on obesity. Finally, we would like to acknowledge that funding for this briefing was provided through support from Novo Nordisk and Eli Lilly and Company. We thank them for their support. We also want to thank you for your time and have a good rest of your day.